So hello out there, this is your instructor Josh, and today I'm going to talk to you about blood and cardiovascular pathologies. This is basically all of the pathologies, pathological conditions that we haven't really discussed over the past, 3 or 4 weeks. Basically all the ones having to do with the blood, all the ones having to do with the heart, all the ones having to do with the cardiovascular system. First thing to keep in mind is many pathological conditions are a result of too much of something or too little of something. And, for instance, we have hypercalcemia, hypocalcemia, hyperperfusion, hypoperfusion, right? Everything like that. So with the blood specifically, we have a few different hyper and hypo things that we can talk about here. One of the first is hypoproteinemia. All right? Remember, from the name hypo means too little. Protein is obviously proteins. So this means that you don't have enough proteins in your blood. Now remember, the blood has basically two main non-water components. You've got the cellular material, that's red blood cells, white blood cells, platelets, and you have protein material. That's primarily your clotting proteins, your albumin, and your globulins, right? Hypoproteinemia means that you don't have enough plasma proteins. So what are the sorts of things that could result in this? Well, first off, starvation, right? So particularly starvation that results from super low protein diets, right? So maybe you are living in a poverty situation where the only thing that you're eating is white rice, or the only thing that you're eating is bread. And this is something that doesn't happen here, but it happens quite a lot in the third world, and used to happen quite a lot more than it does. And in that case, you would be getting sufficient calories to kind of keep yourself alive, but you're not getting any proteins. You're not getting any protein precursors, so that means that you are deficient in the proteins that you can make. Therefore, if you can't make enough proteins, you can't make enough blood proteins, especially since blood proteins need to be replaced on a regular basis. Another possibility is liver or kidney disease. So remember that most of these blood proteins, particularly the clotting proteins and the albumins, are made by the liver. So if you have liver disease, then your liver may not be producing enough of them. And severe burns. Burns typically create weeping wounds that lose a lot of fluid, and that fluid comes from your blood. And so you can lose a lot of blood proteins if you've got severe burns over a large part of your body and don't have that material nutritionally replaced. In an adult, we would just call this hypoproteinemia. And usually it results from a pretty severe case of protein deficiency. In children, there's a disorder called kwashiorkor. And children, as you might expect, especially young children, have very high protein needs because their bodies are growing. So they have to grow more muscles, they have to grow more cells. Those cells have to have proteins in them. They have to grow a lot of connective tissue. That connective tissue is mostly made out of collagen, which is a protein. So just like calcium deficiency is much more serious in a growing child than it is in an adult, protein deficiency is also a lot more serious in children. So this is particularly common in children, particularly in very impoverished environments, where as soon as they're weaned, as soon as they're no longer on breast milk, they're basically fed cereals, bread, rice, that sort of thing. Very low protein foods. Very cheap foods, but very low protein foods. And they basically don't have enough protein intake to even account for their body's growth, let alone to make enough proteins for their blood. And so the symptoms of this are thin arms and legs, because you just don't have enough protein to make muscles for those arms and legs. And swollen abdomen, often due to liver inflammation. So that's too little proteins. You can have too many proteins, but that isn't as common. That would only usually result from some sort of maybe liver cancer that resulted in making too many proteins. Your body regulates that pretty well. But you can have an excess of red blood cells. This is called polycythemia, right? That's too many red blood cells, or specifically red blood cells that are too concentrated, where they make up too large of a fraction of your blood. This can be primary or secondary. Primary means that it is what is causing the problems. Secondary means that polycythemia as a symptom of an underlying problem, that it's being caused by something else. Primary polycythemia is usually a result of a cancer, right? Often a cancer of an erythropoietic cell line. Remember, those are the stem cells that give rise to erythrocytes in the red bone marrow. And so if you have a cancer of those cells, you're going to be making a lot more red blood cells than you really need to. You can have red blood cell counts up to 11 million. That's a hematocrit of about 80%. So that means if you take blood and you spin it down, 80% of that blood is red blood cells, and only 20% is plasma. Right? So that's way too many red blood cells. Secondary polycythemia is too many red blood cells as a result of some other underlying condition. For instance, dehydration. Right? Dehydration doesn't cause your body to make more red blood cells, but it decreases the amount of plasma that you have. Right? Your plasma is a reservoir of water. So if you're dehydrated, the amount of plasma you have goes down, and thus the percentage of your blood that's made out of red blood cells increases. Right? You can also have polycythemia as a result of something going wrong with your body's ability to get oxygen. So for instance, emphysema or high altitude, right? In both of those conditions, your body is not getting enough oxygen. This causes your body to produce erythropoietin, which stimulates the production of more red blood cells. Chronically, if you continue to stimulate EPO production over long periods of time, you can have your red blood cell count rise potentially dramatically, especially if you're abusing EPO for performance-enhancing purposes. It's also possible through physical conditioning. We've talked about how exercise causes your body to naturally release EPO because you're increasing the oxygen demand of your body. And so that results in your body making more red blood cells. An athlete will naturally have a higher red blood cell count than a normal person. Under extreme conditions, especially when you have an athlete who's training at high altitudes or doping with EPO, this can rise to potentially pathological conditions. We think, red blood cells are good. What would be the problem with having too many red blood cells? Well, remember that red blood cells increase blood viscosity, right? Water is the least viscous. Proteins and glucose increase viscosity some. Red blood cells increase viscosity even more. Now remember, if you increase blood viscosity, then you increase blood pressure, all right? In addition to increasing blood pressure, you also increase blood volume because those red blood cells exert osmotic pressure, drawing more water fluid from the body tissues into the blood. This is something that we'll talk about later on. So you have increased blood volume, increased blood viscosity, leading to dramatically increased blood pressure. In somebody in a chronic condition, this can cause problems over time. You overstretch the blood vessels, leading to arteriosclerosis, potentially embolism, stroke, or heart failure. Can lead to aneurysm. You could burst a blood vessel, basically. It leads into all of the same things that chronic high blood pressure can lead into. A more specific blood disorder is anemia. And we've talked about several types of anemia over the course of our class. There are 3 causes, general categories for causes of anemia. Okay? Anemia is any condition in which you're not getting enough oxygen to your tissues. Right? The 3 main causes of anemia are, first off, you don't make enough hemoglobin or red blood cells. So if you don't make enough hemoglobin or you don't make enough red blood cells, then you're going to be insufficient at transporting oxygen to your tissues. This is the most, I don't want to say the most common cause, but it is the most common primary cause of anemia, where anemia is the condition that needs to be treated. What could result in not making enough red blood cells? Well, you could have insufficient EPO, right? If your body doesn't make enough EPO, then you don't make enough red blood cells, and your red blood cell count goes down. Kidney failure. EPO is produced, among other places, by the kidney. You could also, if you have kidney failure, you could be losing red blood cells, although that's technically hemorrhagic anemia, but we'll get into that in a second. Iron deficiency anemia, which we've talked about before. If you don't have enough iron, you can't make enough hemoglobin. Hemoglobin requires iron. Too little iron, not enough hemoglobin, not enough oxygen transport. Too little iron could be a nutritional deficiency. You're not getting enough iron in your diet. Or it could be a result of a failure of the body to properly absorb iron that you are eating. For instance, in the case of people with Crohn's disease or inflammatory bowel syndrome or celiac disease, they may not be absorbing the iron that they're eating. Pernicious anemia, this is an autoimmune attack of stomach lining. And in your stomach tissue is where you absorb vitamin B12, and vitamin B12 is necessary for red blood cell production. So if you have this autoimmune disease, you are vitamin B12 deficient and therefore anemic. This is treated by supplementation with vitamin B12. Last is, so anemia can be described as either hypoplastic or aplastic. Hypoplastic means you're not making enough red blood cells, but you are still making some. Aplastic anemia is where you just stop making red blood cells or stop making hemoglobin altogether. Obviously, it's more acute, more severe. So all of those are problems on the production side. You can also have anemia that results from a loss of red blood cells or a loss of hemoglobin and iron. All right? These are hemorrhagic anemias, anemias that result from bleeding. Now, obviously, if you have an injury, you come into the operating room and you're bleeding out, you've had a lot of blood loss, then it's obvious that you're anemic. Because you just lost a lot of blood. It's also probably not your most severe problem. Your biggest problem is that you need to stop losing blood. Then you can worry about the anemia afterwards. But less severe hemorrhagic anemias happen all the time. In fact, women of premenopausal but post sexual maturity age, it happens pretty much every month. When women go through their menstrual cycle, they bleed, and that bleeding causes them, or can cause them, to become slightly anemic. That is a form of hemorrhagic anemia. It's caused by bleeding, by loss of iron through blood loss, basically. You can also have hemorrhagic anemia due to severe kidney failure, when you actually start peeing blood out, or any sort of internal gut bleeding that causes you to lose blood from your feces as well. Last, we have what are called hemolytic anemias. This is where your blood is not leaving your body necessarily. You're not hemorrhaging, you're not bleeding, but the blood cells are nonetheless dying. So this is this is anemia from red blood cell destruction. This can have a few sources, almost all of them the result of some sort of pathology, right? So it could be a hemolytic anemia that results from an improper blood transfusion, right? You got a blood transfusion from the wrong blood type, and it had the wrong antibodies in it, and it caused a bad reaction. It could be a hemolytic anemia from from a bacterial or potentially viral infection, or even protozoal. People with malaria parasite will become hemolytically anemic whenever, at certain parts of their disease cycle, when the parasite bursts forth from their blood vessels. There are certain bacterial infections that when they go septic, they can produce a hemolytic toxin that will destroy red blood cells. That can cause hemolytic anemia. You could also have hemolytic anemia that occurs particularly in newborn infants as they make the transition from fetal hemoglobin to adult hemoglobin, and that is usually a temporary condition, but under certain circumstances it can be a severe one. It may require a fetal blood transplant or a baby blood transplant, basically. So what are the consequences of anemia if you have it? Well, pretty obvious. You're not getting enough You're not getting enough oxygen to your tissues. Your tissues need oxygen to survive. So what happens if they don't get enough oxygen? Over the long term, Like over the short term, what you get is hypoxia, just hypoxia, low oxygen. That's the general term for failure to supply oxygen to the tissues. And if it proceeds long enough or is severe enough, necrosis, which is tissue death. In a case of anemia that is not immediately causing tissue death, what are the sorts of symptoms that you might observe? So, patient might be lethargic. They lack energy because their tissues, including their brain and their muscles, are not getting sufficient oxygen, so they just get tired very easily. Easy shortness of breath, like they might just stand up from a chair and then be winded from that, or have a hard time after even a short walk. You may notice a rapid breathing and an increased heart rate as the body tries to compensate for the anemia by pumping blood faster and more blood faster, and increasing the respiration rate to increase the amount of oxygen that's getting into the blood. So increased respiration and heart rate can be symptomatic of anemia. On the longer time scale, life-threatening necrosis, particularly of vital metabolically active tissues. Like if you just sit there and don't exert yourself, then most of your muscles don't use a lot of energy. Your epithelial tissue doesn't use a lot of energy. What does use a lot of energy all the time? Your brain does, your heart does, and your kidneys often do as well. They've got to filter your blood pretty much constantly, and that actually takes a lot of energy. So those are going to be very oxygen-intensive organs, and they are going to be the first ones to fail. And they're also pretty important. If you do not have enough red blood cells, for whatever reason, you're not making enough or you're losing too many, well, remember we said that red blood cells are more viscous, and the more red blood cells you have, the more viscous your blood will be, the higher your blood pressure will be. Conversely, if you're not making enough red blood cells, your blood becomes less viscous and your blood pressure goes down. Not only that, but we said that when you make more red blood cells, that's going to osmotically pull water from your tissues into your blood. The logical corollary of that is if you have too few red blood cells, then you are going to draw less fluid from your tissues into your blood, potentially resulting in tissue edema, low blood pressure, which will cause the body to attempt to, because low blood pressure is bad, low blood pressure will kill you quick, your body will attempt to compensate for that low blood viscosity by increasing blood pressure through increasing heart rate, or decreasing blood vessel diameter. In fact, probably both of them. This can cause the heart to race, which can eventually lead to cardiac failure as you overstress the heart. The heart's racing, it's beating faster, but it was already not getting enough oxygen because you're anemic. So you're putting an increased demand for oxygen on it at the same time that you are making that you are not getting enough oxygen to it. Just as an example disorder, sickle cell anemia is a hereditary form of anemia. It's caused by a single amino acid change in the hemoglobin. Right? So it's just one single amino acid difference in the hemoglobin, and it's in specifically the beta chain of the hemoglobin. So it's not even all of the hemoglobin. That one change decreases its affinity for oxygen. It also changes the way it packs inside of the cell. So red blood cells that are affected by this become rigid, sticky, and sickle-shaped. Red blood cells are around for a reason. It allows them to fit well through capillaries without catching on the sides of the artery or catching on each other. These sickle-shaped cells can like hook to each other and stick to each other, causing basically micro blood clots. Those microclots can do a lot of vascular damage. It's like you've got embolisms, minor mini embolisms happening all the time. And that puts a lot of stress on the capillaries of the tissues, particularly in organs that are very capillary rich, causing damage to them. And even if you don't die from the anemia, you often die from the blood pressure or the blood vessel damage as these sickle-shaped cells catch on each other and catch on the tissue around them. So they clump together, blocking small blood vessels, causing small embolisms all the time, causing potentially heart failure, kidney failure, stroke. Again, there's that brain, heart, kidney combo. Also, joint pain and paralysis. They decrease the. Can't remember if it's decrease or increase. They cause damage to the cartilage in the joints. If you have one bad sickle cell gene, but just one, you have one good sickle cell gene as well, one good hemoglobin gene, I should say. You are what's called a heterozygote. And under most circumstances, you make sufficient good hemoglobin that you're unaffected by the disease. Although I should point out that you're still slightly anemic if you're a heterozygote. It's not enough anemia that it matters under most circumstances, but it can fail you at very high altitudes. So people with sickle cell anemia, not even with sickle cell anemia, people who are just carriers, who are heterozygotes for sickle cell anemia, can begin to become symptomatic if they're up in the high mountains. In, say, if you're up in the mountains around Denver or Flagstaff or someplace up pretty high where the air is thin, then their condition can sort of manifest. So they're probably never going to be professional skiers. And in fact, they may have some trouble being professional athletes of any sort, as they will have trouble if they increase the oxygen demands of their body. But for normal bodily function, they should be fine. In fact, better than fine in some circumstances, because it turns out that little difference of dropping the oxygen level just a little bit makes them resistant to malaria, which is why the sickle cell disease, even though it's so nasty, is still reasonably common. Because even though if you have both of them, you're probably going to die without serious medical treatment. If you have only one, there are parts of the world where it will protect you from this horrible disease. Malaria has probably caused more human deaths over the course of history than any other single disease. What else can happen to your blood? Well, we've talked about blood's capacity for carrying oxygen. One of the other things that we talked about in an earlier video was how blood helps protect you by clotting. That's called hemostasis. So another blood pathology that you can have is a clotting disorder. That would be either a deficiency in clotting, meaning your blood doesn't clot or does not clot reliably, or you can have an abundance of clotting. Your blood clots when it shouldn't clot. Deficiency of blood clotting is almost always a result of a genetic condition, that genetic condition being called hemophilia. There are several different genetic varieties of hemophilia. There Well, two of them are sex-linked recessives, meaning that males need one bad copy and females need two bad copies. And specifically, this is a deficiency in one of the factors. So hemophilia A is the most common. It's 83% of cases, and it is a deficiency in factor 8. Hemophilia B is a deficiency in factor 9. That's about 15% of cases. Both A and B are going to be significantly more common in males than females because males only need to have one bad copy. Hemophilia C is a deficiency of factor 11, and it is autosomal, meaning it happens on a non-sex chromosome, so it will happen equally in males and females. Unless you are on basically some pretty serious clot-busting drugs, these are the main causes of hemophilia and clotting deficiency. There are some drugs that you can be on, warfarin, other stuff like that, where if you take them, you are effectively become hemophiliac while you're on the drug, because they interfere with one or more of the clotting factors. Having clots that occur when they shouldn't occur is the opposite side of that coin, and that is called thrombosis. A thrombus is a blood clot. So thrombosis is abnormal clotting of the blood. It's blood that clots when you aren't injured and when you don't have a broken blood vessel. Thrombosis can happen in anyone, but it is much more likely to happen in people with particular genetic conditions, or in particular people with particular lifestyle conditions. Any blood that is let to sit will clot. If we take blood and we draw it from your veins or from your artery and let it sit in a test tube, it will start to clot. It's the fact that your blood is under motion all the time that stops it from clotting, or at least that's a major thing that stops it from clotting. So clotting, or at least thrombosis, very seldom happens in an artery, because blood is always moving through your arteries. But if you remember, the pressure in veins is much, much lower. And the flow through veins is increased with exertion, with exercise, as you have the muscular pump compressing the veins and moving blood back to the heart. Particularly in people who are inactive, that blood can pool for long enough that it begins to clot. This most frequently occurs in the leg veins because they are, your leg veins are where basically the blood pressure is lowest, where the perfusion is lowest, and it's in the leg veins of inactive people, people who are bedridden, people who are injured or sick, and also people who are constricted. So, for instance, if you have a genetic condition that makes thrombosis more likely, you have a variant of one of the clotting factors that makes it so that your blood clots easily, then it can be dangerous to go on long flights or long bus trips or long anything where you can't get up and walk around. This is pretty easily resolved. You just need to get up and walk around every, 45 minutes to an hour. Stretch your legs, walk up and down the aisle a little bit, then get back in your chair. But if you can't do that, and often moving around is a lot more restricted on flights than on other modes of transport, then they recommend that people with this condition either take blood thinning agents before going on a long trip, or notify the staff of the airplane that they have a medical condition that means that they need to get up and walk around every hour or so. If you have a blood clot that occurs in your leg, that blood clot is now a solid thing that's moving through your cardiovascular system. It's in the leg veins are pretty big. It will eventually get to something that is much smaller than that. And when that happens, it will get stuck. And when it gets stuck, it can prevent blood from passing it. This is called an embolism, or an embolus. An embolus does not have to be a blood clot. It can be anything that can move around the body through the bloodstream, lodge somewhere, and block blood flow. It is most frequently a blood clot, but there are emboluses that can result from, for instance, bacterial growth, or something that gets into the blood externally, like possibly through an injection or something like that, or through a surgical means. If an embolus lodges in the lungs, blocking the capillaries of the lungs, that is a pulmonary embolism, which basically causes a little explosion of tissue death in the lungs. It can be quite severe to have bleeding in your lungs because that will reduce your ability to absorb oxygen. If the clot however, it should be said that the tissue in your lungs, if the clot lodges there, the tissue in your lungs isn't going to suffer from oxygen loss because it's your lungs. That's where the oxygen is. If it lands anywhere else and blocks blood flow, that results in an infarction. An infarction is tissue death, usually due to some sort of obstruction of the circulatory system. The most common, or the most severe infarctions, the one that we're going to worry about, are infarctions of the heart, which are called heart attacks, and infarctions of the brain, which are called strokes. Myocardial infarction is what we call an infarction or a blockage that stops blood flow through one of the coronary arteries. Those are the arteries that feed blood to the heart. So if you have an infarction someplace, for instance, right here in this black circle, everywhere downstream of that will no longer be getting blood. And heart tissue needs oxygen constantly. If it doesn't get oxygen for even a few minutes, it starts to die. And you can't replace cardiac muscle. When it dies, it's gone for good. You replace it with scar tissue and you lose function in that area. So a myocardial infarction is the sudden death of a patch of myocardial tissue resulting from some sort of blood instruction. Okay? There are several different types of myocardial infarction. A type 1, and they all sort of start the same way. Well, at least most of them start the same way. They usually start with a constricting of the artery due to fat deposits called plaques. And I'll talk to you about exactly what plaques are in just a second. A type 1 myocardial infarction is where you have a coronary artery that has been narrowed due to this plaque buildup. So the plaque builds up, causing constriction of the artery. That means that under stress, for instance, if you're exercising, you can't get sufficient blood to that muscle tissue, causing angina or heart pain, chest pain, basically. Angina is a specific type of chest pain. It's not just pain, it feels like pressure or squeezing pain that radiates down the left arm. It feels almost like somebody's kind of jabbing you with the end of a stick, or has actually sort of, is maybe squeezing your heart, and it's not very well localized because the visceral nerves aren't very precise. So if you have a restriction, then you can suffer angina upon exertion. But you may not suffer angina or heart pain when you're not exerting yourself, when you aren't racing your heart. However, let's say you have a thrombus, an embolus that forms either somewhere else and lodges here, because this is now a much constricted area, an embolus that would usually flow through, will get caught here, and that will stop blood from going further. Secondly, if you recall from our lecture on hemostasis, blood vessel walls are covered in platelet-repelling material that stops platelets from causing clots, right? And that's why platelets only cause clots where you have some sort of injury in the artery or blood vessel that exposes the collagen underneath. Well, this plaque here covers up those platelet-repelling structures, those platelet-repelling proteins. And if the plaque ruptures, it can look very similar to a ruptured artery, causing the blood around it to rapidly clot. And so you have this plaque, which is covered part of the artery. It ruptures, and then even though the blood vessel is fine, your platelets see this as being a blood vessel rupture, and they clot in that area, and they can clot so much that they fill up this restricted space, causing a heart attack. You can also have a type 2 myocardial infarction. This is caused by a vasospasm, usually the result of something causing the artery to constrict in a particular area, potentially something like a tumor that is constricting it, putting pressure on it, or something that causes a very localized blood vessel constriction, a very localized vasoconstriction to that area that then restricts blood flow through. Another type 2 myocardial infarction is you could have a severely restricted artery. So here we have an artery that's about 90% restricted, and that means that blood can only very slowly flow through there. If this person gets up out of a chair fast, or even suffers a fright, they're watching a scary movie or something and it causes their heart to race, it's entirely possible for them to work their heart faster than they can get oxygen to it through this constricted area. And that could cause a heart attack. Last, and this is pretty rare, you could have a supply-demand imbalance alone. So there's no constriction here, but something happens that causes you to work your heart so fast, so hard, that your heart just cannot supply itself with sufficient blood. This is usually only going to happen if you have some sort of anemia or pulmonary condition where the blood that you're feeding your heart is improperly oxygenated. or if you are on some sort of drug, for instance, you're taking cocaine or meth or something like that, something that's going to cause your heart to exceed its normal boundary conditions. Normally, your heart just would slow down, but you're telling it continue beating faster and faster and faster, right? They say, your heart explodes or something on a drug. Your heart isn't really going to explode. But it is possible to overwork your heart to the point that even healthy arteries cannot supply it with enough oxygen if you have sufficient chemical imbalance. Sometimes angina does not occur with a heart attack. You can have like a mini heart attack or a micro heart attack, what's called a painless heart attack. And this can actually disrupt. Remember, we talked about how there are certain parts of the myocardial wall, like the Purkinje fibers, the bundles of His, and all of those things that are carrying electrical signals throughout the atria. Well, if those cells die due to a heart attack, even a small heart attack, it's like, you cut the wire that leads to the light bulb. The signal can't pass through anymore. And so even though you have a relatively small part of your heart that's dead, it means that you might have stopped an entire part of the heart from working. Like, you've just got a very small part of your heart that dies, but that part of the heart happens to be on the fiber that leads from the right atrium to the left atrium, and now that signal can't get across, and so your left atrium isn't contracting anymore, and that means that you're going to have less cardiac output and can lead to greater cardiac damage down the way. These sort of silent heart attacks are most common in people with arterial disease, particularly diabetics and the elderly, and people with arteriosclerosis, which corresponds to both the elderly and diabetics. So, all of this leads to a discussion on coronary artery disease. Basically, what I just told you about, where you have a buildup of plaques on the arteries, that's coronary artery disease. Coronary artery disease, or CAD, is usually it usually starts off with arthrosclerosis. Arthrosclerosis is a hardening of the arteries that is caused by an accumulation of lipid deposits, cholesterol, fat, protein, that basically start sticking to your arterial wall. And usually you'll have like some micro injury that makes it so that the wall is no longer like perfectly smooth. And then you have fat that sort of starts sticking to that injury, and then fat sticks to more fat, which sticks to more fat, which sticks to more fat. And you get an arteriosclerotic lesion, effectively. Well, this sends out some inflammatory signals, causing monocytes to penetrate the area. Now remember, monocytes are white blood cells, and they are phagocytes. So under normal circumstances, their job is to go in and clean up garbage, also to kill bacteria. But when there's no bacteria around for them to kill, they clean up garbage. And so usually, if you have a little bit of cholesterol or plaque buildup, the monocytes will go in there, they'll eat it away, you're done. Boom, fine. But what happens if you're laying down fat deposits faster than your monocytes and macrophages can eat it up, right? So then your monocytes are going to penetrate the damaged blood vessel into the plaque area or into the fatty deposit area, start trying to eat away that fat, that cholesterol, sorry. cholesterol that is sort of glommed on there, and then the macrophages themselves start to get fat. All of that fat and cholesterol that they've been eating goes into their membranes, and so they get larger and they get stickier, and they become what's called foam cells, and then they start to sort of stick together inside of the plaque, inside of the fat deposit, which now becomes an atherosclerotic plaque or an arthroma. Once the atherosclerotic plaque has formed, like I said before, it's now covering up that platelet-repelling lining of the blood vessel wall. And so platelets can adhere to the plaque, causing clotting, potentially. They also, because they assume that this is a damaged area, this is something that needs to be repaired, they secrete platelet-derived growth factor. This is a growth factor that causes cells to divide, and it also causes inflammation. It attracts more immune cells, meaning more monocytes and macrophages, as well as lymphocytes and other things, and it also promotes mitosis of muscle cells, fibroblasts, depositing collagen. It basically assumes that you have a cut or tear in this artery. You don't have a cut or tear. What you have is a plaque deposition. And so in trying to repair it, it just lays down more and more tissue, causing the artery to become narrower and narrower. And this causes a mass that obstructs the artery. So here you can see the progression of coronary artery disease. You have an initial deposit of fat and cholesterol. This will get inundated with monocytes and macrophages, attracting other immune system cells that lay down layers of collagen, that then attract more platelets, that then attracts more tissue, that makes an area that's easier for fat cells and cholesterol to hook onto, and you get basically a positive feedback loop, a slow one, but still a positive feedback loop that builds up, constricting and obstructing the blood flow over time. It can go anywhere from like a 5 or 10% blockage, which is probably not going to affect you very much, assuming you're not an athlete or something, to something like a 70 or 80% blockage, which means that you probably have a hard time exerting yourself at all without inducing angina, to like a 95% blockage, which means you're basically in a constant state of semi-heart attack. So what are the risk factors and treatments for coronary artery disease? The greatest risk factor for coronary artery disease is excess LDL levels. You may know of LDL as the bad cholesterol. It's basically, what it stands for is low-density lipoprotein. Cholesterol and fat are hydrophobic, so they don't like moving around in your blood by themselves. So your blood's water. In order to move fat and cholesterol around, there's a protein that transports them. When this protein is full of fat and cholesterol, we call it LDL, because it's sort of spongy because of all the fat and cholesterol it's absorbed. If it's over-absorbed fat and cholesterol, then we call it VLDL, for very low-density lipoproteins, and those are especially dangerous. HDL, what's called the good cholesterol, is basically this lipoprotein, except it's got less, it's less full. So it's like a dry sponge. It can absorb more cholesterol and lipids from your blood, helping to protect you. So that's why you want low LDL levels and high HDL levels. These LDLs stick to defective receptors in arterial walls, and that's how the plaque or the pre-plaque lesion gets started. Dysfunctional receptor, so it's a combination of high amounts of LDLs and dysfunctional receptors in arterial cell walls. Raising either of these problems increases coronary artery disease. However, it's not the only risk factor, right? So some other risk factors, some of which are unavoidable. Heredity. Heredity plays a pretty big role. Aging. Damage accumulates over time. The older you get, the more damage accumulates. Being male, testosterone levels particularly increase the likelihood of coronary artery disease. Males have higher testosterone levels, therefore higher risk factors. There are also a lot of preventable risk factors as well. Obesity, right? Well, if you're obese, then you've got more fat floating around your body. Not only that, but if you're obese, then that means you've just simply got more body. All of that body has to be fed with capillaries, which means you need more blood, and which means you need more blood pressure to perfuse all of those tissues. So obesity itself leads to high blood pressure. Smoking. Smoking causes a whole bunch of different types of damage. Nicotine basically is a toxin. It causes cell death all over the place. Smoking also reduces the amount of oxygen you can get into your lungs or into your blood by damaging the lungs, and it's a super potent vasoconstrictor, shooting your blood pressure up through the roof. So that's a problem. Lack of exercise. Lack of exercise is probably, I would say, other than smoking, is the main contributor to coronary artery disease. Exercise has been shown to basically help prevent and repair these pre-plaque lesions. Once they become plaques, they're really hard to get rid of. But if you just have a fat deposit that hasn't yet turned into a plaque, it can go away. But only if you have good, healthy veins and arteries. Anxiety, which increases blood pressure. Stress increases blood pressure. Aggression increases blood pressure. And diet, which increases fat content, cholesterol content, obesity, lack of exercise, and everything like that. What are the treatments for coronary artery disease? Well, let's say we take a look in there and we discover, you've got a 75% blockage in your, left circumflex, artery or whatever, right? What are we going to do about it? Well, there's basically two things that we can do. Well, there's three things that we can do. First thing that we're going to do is treat you medically with drugs, right? If it's a 75% blockage, drugs are probably going to maybe help prevent the damage from getting worse, but they're not going to clean it away. If you've got very early stage coronary artery disease, drugs, Lipitor, cholesterol-lowering drugs, can help to clear it up and to prevent it from getting worse. But it's already pretty bad, so what are we going to do? Well, we've got two options. We can either give you a new artery, or we can try to fix the one you have. Giving you a new artery is basically coronary bypass surgery. With that, what we basically do is we say, all right, so you've got, this is your normal artery here. All right, but you've got this sclerotic plaque, which is cutting off 75% of the blood flow through this area. So we're going to take a small vein from your leg or a small thoracic artery, basically just snip it out of your part of your body that isn't going to be as vulnerable as your heart, and then just go sort of sew it into place. You make a little hole here, you make a little hole here, and you just sew this thing into place. And now the blood can get around the blockage. That's bypass. The other thing that you can do is what's called angioplasty. This is where, let's say you have, again, you've got your artery, and it's got a blockage in it. So what are we going to do? There's actually a few different methods, but the most common is what's called a balloon angioplasty, where we basically insert this little balloon, and then when it gets into the blockage area, we're going to blow it up. Right? And so here's our balloon that we put in. You know, we blow up the balloon, and yeah, that does like shut off this artery for just a second. But we're just going to blow up this balloon for just a second, and then that's going to basically crack open the artery. And now, your artery has been restored to full size. We'll also sometimes put in a stent, right? So the stent is going to be basically a tube here. That's going to prevent this artery from basically collapsing back in on itself after we cracked it open. Usually, bypass surgery is more invasive. You basically got to open somebody up and tie in a new vein. Angioplasty is less invasive, but it does require, well, angioplasty is more successful the less damage there is. So if you've got a 75% blockage, angioplasty, we can usually balloon that thing up. If you get a 95% blockage, you're probably going in for emergency bypass surgery.